All right, good evening. It's the 2nd of April, 2015, Bio 100 DLO1. This week we'll be covering the respiratory system. Okay. In general, the respiratory system is responsible for bringing respiratory gases into the body and expelling metabolic waste from the body, okay? Specifically carbon dioxide moving out and oxygen moving in. And we do this by a series of different organs, all associated with the respiratory system. And we'll define the entire process of gas exchange between the environment and the body as respiration. And we have to differentiate because we have two different types of respiration. We have external respiration, and then we have internal respiration. All right, so in differentiating between these two, external respiration is the process by which, excuse me, we bring in the exchange of gas, we'll call it that, between the environment and the blood. Okay, in other words, we breathe in, about 21% of the air that we breathe in is oxygen, and that oxygen flows through the organs of the respiratory system, where it gets down to the area of gas exchange. Oxygen diffuses into the blood and is carried throughout the blood to the cells to provide the necessary ingredient, if you will, for cellular respiration. Internal respiration is the exchange of gas between the blood and the cells, and the body cells. Now this external respiration is accomplished by two processes referred to as pulmonary ventilation, which you already know involves one, inhalation and exhalation. Okay, and so what I'm going to focus on is you'll need to go through the different organs that compromise or that make up the respiratory system, because there's no point in going through the mouth, the nose, larynx, the pharynx, the trachea, bronchi, bronchioles. I will focus though on the actual mechanism of gas exchange, not only in the lungs but also in the tissues. There is an equation that we need to become intimately familiar with, and that is this. Carbon dioxide plus water reacts together in a reversible reaction to form a substance called, carbonic acid, which in a reversible process dissociates into a hydrogen ion. If you remember, hydrogen ions are associated with acids, and the bicarbonate ion. Okay. Now, why is that important? Well, because this process goes on. When we get down and we talk about internal respiration, through the process of cellular respiration, the body produces large amounts of carbon dioxide. That carbon dioxide diffuses out of the cells into the blood, combines, most of it does, combines with water to form this substance called carbonic acid, which then further dissociates depending upon the body's or the blood's pH condition into the hydrogen ion or proton and the bicarbonate ion. The point here is, and this is an important point, so I put a little asterisk by it, most of the metabolic CO2, carbon dioxide, is carried in the blood as the bicarbonate ion. And if you remember, and that is the HCO3 negative, okay? Now, what happens is, at the tissue level, at the cellular level, all of this carbon dioxide is produced, diffuses into the blood. Because there's more of carbon dioxide, or a higher concentration of carbon dioxide at the tissue level, at the cellular level, than there is hydrogen ions or bicarbonate ion, the reaction proceeds in this direction. This reversible reaction is concentration gradient driven. In other words, when there's more of this than there is of this, reaction will proceed in that direction. When there's more of this than there is of this, the reaction will come back in the reverse direction. Now this, in the forward direction, this occurs at the tissue level. Cells are producing carbon dioxide constantly through cellular respiration when we produce energy. And so that CO2 diffuses into the blood. There's an enzyme actually that catalyzes and speeds up this reaction that's called carbonic anhydrase. And you'll notice that it's an enzyme because it ends in the suffix ase. Okay? And so then this metabolic waste, this carbon dioxide, in the form of a bicarbonate ion, and if you look, you can see there's a CO2 in there somewhere. Until it gets back to the lungs, at which time there is more of this bicarbonate than there is carbon dioxide, because ambient air contains only about 0.03% CO2. The point being is then that the reaction is driven back this way. The bicarbonate ion goes through this reaction, comes back to its CO2 form, and then we breathe that out. Okay, but this one reaction, we need to understand what it does and where it does it. It proceeds in this direction at the tissue level, because that's where the carbon dioxide concentration is the highest as a consequence of cellular respiration. And then when we get back to the lungs, when the blood comes back into the right side of the heart, right atria, right ventricle, pumped through the pulmonary artery into the lungs, because there's a high concentration of this, the reaction proceeds in this direction, the CO2 comes out, and then we breathe it out, okay? All right, so most times when we think about respiration, we think about breathing in and breathing out. Technically speaking, that's referred to as pulmonary ventilation, i.e. inhalation and exhalation. Okay. We know, and again, you'll just kind of go through the organs that are involved in this. The nose, the mouth, the pharynx, the larynx, the trachea. Now there is an important structure at the entrance into the trachea, which is the so-called windpipe that I'm going to mention, and it's called the epiglottis. If I put an asterisk by it, that means make a note of it. Okay, and what this is, it's a flap of cartilage, because at least the pharynx, okay, is a passageway for not only air but also food. Okay, and it doesn't split until we get to the larynx. This part, you know, the so-called voice box. Then it splits, and then we have the trachea that comes in the front, and then the esophagus that will go in the back. So when we eat, there is this structure called the epiglottis. When we swallow, the tongue will push on it. It's a flap of cartilage, and it will cover over the trachea so that what we're swallowing doesn't end up in our lungs. Okay? So it protects the trachea from food. Okay? Now, in our voice box, there is a, and I'm going to mention this as well, we have our, how we produce sound is we have vocal cords. All right, these thin membranes stretch across the trachea, and how we produce sound is we force air out of our lungs. Okay, like if you say, hold your hand in front of your face and say the letter P, you can feel the air coming out. Okay, and the opening between the vocal cords is called the glottis. And you've probably had experience with this if you've ever swallowed something and it went down the wrong pipe, so to speak, and it ends up in your trachea, settling down on your vocal cords, and what they do in response to that, in a spasm, they'll slam shut. So you can't get air in because they're slammed shut because something is on them, food, water, some sort of liquid. And so what do?
Cough?
You cough. You rhythmically contract your diaphragm to force air through those vocal cords to remove or try and remove whatever is sitting on them. Then you'll notice for a few minutes after you've gone through a very good coughing spell, you can't speak because you're like, and that everything is sort of heightened, and it takes you a few minutes before you can start breathing and speaking again. All right, but remember these two structures. The epiglottis, it's cartilage, and this was a structure that was very near and dear to my heart because when you intubate somebody, when you put a tube down into their trachea, you can either use a straight blade or a curved blade. My personal preference was a straight blade, but you tilt the person's head back, you stick the blade down in, and you lift up on this cartilage flap so that you can insert the tube down into the trachea. Okay? All right. I do want to bring this up because I remember seeing reference to that. Now, as part of our entire respiratory system, we have 4 sets of, and by the way, it's better to breathe through the nose, in case anybody asks, because in our nose we have hair designed to trap garbage from the air. It has a very good blood supply, so as the air moves through our nose, it is warmed and it is moistened because dry air is very irritating to the respiratory tract. As opposed to mouth breathing, which if you are a mouth breather, when you wake up in the morning, your tongue's all dry. It's like your mouth has been You've been eating sand all night. All right, we have 4 sets of what are called paranasal sinuses. Okay, and these are normally air-filled sacs lined with mucous membranes. Okay, and how they function is, for one, they lighten up the head, because this is good sized bowling ball on our shoulders, but they aid in what's called phonation, or sound production. Okay, and an important point about that is that they are continuous with the nasal cavity. Okay, so should foreign material enter into these sinuses, and should an immune response be elicited, of course, then the sinuses may start to fill up with fluid, bacteria perhaps. You may even get a nice infection in there, and then get all of the metabolic products from the bacteria, and your nose will be all stuffy, your head will hurt. You'll also notice that you don't taste things very well because you can't smell them, because it's just all clogged up. These sinuses are the these 4 sets, frontal sinuses, and those are here, here up above your eyes. And you'll see then there's the maxillary sinuses. Guess I should put plural. And those are here right below your cheekbone, the top of your cheekbones there. And you have your ethmoid, which are deeper inside the skull. And then you have your sphenoid sinuses, okay? And again, these correspond with bones in the skull. Okay? And an important function of those, again, is to aid in phonation, or in sound production. There's a woman that always comes to mind when I talk about the sinuses. Has very famous sinuses, made a lot of money off of them because she had quite a unique voice, and that is Barbra Streisand, whose music I like. But the setup of her sinuses and the way she produces sound, she produced a very unique and very successful sound. Okay, I'm not going to go through the different organs of the respiratory system. Safe to say that we have the mouth and the nose. Okay. Now remember, the mouth is also part of the digestive system. Then we have the pharynx, which is divided into 3 parts: the oropharynx, the nasopharynx, and the laryngopharynx. And there, I guess, is some dispute as at what point when we swallow does reflexive action take over. And actually, you know what? I think I have those back. Let's do the nasopharynx first, and then the oro. Because it doesn't. I bring it up because there may be reference to, when does the reflexive part of swallowing kick in, and it's after the food bolus is entered into the oropharynx and it starts to get into the esophagus, you don't control it anymore. To a point. You know that if you try hard enough, you can bring up food again and chew it again, or if you want, but for the most part, the reflexive action starts after it enters and passes through the oropharynx. And then the laryngopharynx is that part that is just above the larynx, just above the vocal cords. Okay. Take home message.
Repeat that. So the oro, you say you lose control. What? Tell me about the control again.
Okay, when you swallow.
Yeah.
Okay, when we eat.
Yeah.
We spend a lot. Hopefully, we spend a lot of time chewing up food, moving it around in our mouth, and our tongue does that, and forming it into a ball, into a bolus, and then our tongue will shove that bolus into the back of our pharynx, past the nasopharynx into the oropharynx, and then at a certain point, it starts to enter the esophagus. And then the smooth muscle of the esophagus will take care of the reflexive action to move it from the oropharynx down into the stomach. That's why you can stand on your head and eat and drink, and whatever it is you're eating and drinking will still make its way into your stomach against the force of gravity because of this peristaltic action of the smooth muscle of the esophagus. It's important to note, though, again, that pharynx is not only part of the respiratory system, but also part of the digestive system, okay? Remember your sinuses, and remember they are continuous with the nasal cavity. All right, so when you start to get drainage, if, should you encounter some foreign material in any of these sinuses and they become inflamed, or bacteria get in there and you get a sinus infection, if you've ever had one, you know what I'm talking about. It can be very painful because those normally air-filled sacs fill up with fluid and it puts pressure. And pain receptors in the skin pick up on that pressure and go, ouch. And then when it starts to drain, of course, drains into the nasal cavity and then into the nasopharynx, and a lot of it we swallow, or it tickles and we cough and sputter and spit to try to remove all of this material from our body. All right. Now, once we get past the laryngopharynx, we go into the trachea, the so-called windpipe. I guess we will go through a little bit of this. Now, the trachea is the windpipe. And a unique feature about the trachea is that because it is located anterior to the esophagus is behind it, all right? It is protected by cartilage, C-shaped cartilage. They look like that, and they open to the back because this is where the esophagus runs down. And the interesting thing is when you do an intubation and you lift up the esophagus, and if you look on these diagrams here, you're looking down now right through the vocal cords. Well, once you look down into that diagram, you can see those rings for a while. There's 7 or 8 of them, and they're C-shaped, and they're just for protection because you got to think this thing is pretty exposed, and a good shot to the larynx and breathing, being able to get air in, stops. Okay. We talked about the larynx, glottis, epiglottis. Now, also another thing to remember is that a lot of the membranes that line our respiratory tract, they contain these cellular processes called cilia. Okay, and these are they're multiple hair-like processes that function to, when we breathe in, you know, we have mucous membranes that line our tract. They produce mucus. The whole, you know, the idea being, when we breathe in, there's a lot of garbage in the air. We want to trap as much of it as we can before that air reaches the place where gas exchange takes place. And these cilia, they move, they beat upward. And so we produce this mucus on 24/7, okay? So that it'll trap any garbage in the air. And I'm talking about when we get outside the trachea and get into the primary bronchi and the main, you know, the right and left main stem bronchi, like what I just did. That's mucus. It's been produced by these goblet cells in our mucous membranes, and these cilia, they beat to move the mucus upward so that we can get it out of our respiratory tract. You can spit it on the ground. Most times we swallow it. And it's these cilia that are affected by cigarette smoke. Chronic cigarette smoking over many years essentially renders those cilia non-functional or less functional. If you live with a smoker, or you've been around a smoker and you've been around them early in the morning after they've been asleep for 8 hours, and these cilia that line the respiratory tract, most of it, don't work effectively. Those people, when they wake up, they sputter and spit and cough, and they got to make an effort to get the mucus and the garbage that has accumulated throughout the night to get it out so they can breathe. Normally, if you don't smoke or you don't have any other associated respiratory disease, those cilia take care of that, and it moves it up and out, and you know, you get up in the morning and you swallow it. Okay? All right, but it's important to note that our trachea is protected by these rings of cartilage, and again, they look like this, and they'll line it going all the way down, because behind it is the esophagus, and you don't want it to be a complete ring because that would block the esophagus, make it hard to swallow. All right, talked about the glottis, the epiglottis. I'm not going to get too weird about differentiating between the true vocal cords and the false vocal cords. I do want you to be aware of the epiglottis. Now there is a place, and you learn this if you're going to engage in emergency medical training, you know, be an EMT or whatever like that.
Do those C-shaped cartilage ever? I'm trying to figure. A lot of older people have trouble swallowing. Is that because the cartilage is starting to narrow?
Probably not. No, because those are, you know, I mean, when they're developed, that's the shape that they are. Difficulty swallowing could, you know, dysphagia. There could be a variety of reasons for that. One of them is stenosis, just a narrowing of the esophagus, and I've seen that treated as well. And I don't know if you have, but those folks have to swallow these rubber tubes that get progressively larger to open up the esophagus. But strictures or stenosis of the esophagus can help explain why people have trouble swallowing. Certain drugs can do that as well, particularly like you know, long-term use of opiates sometimes can make it a little difficult to swallow. Okay, what was I doing? All right, now I wanted to bring this up because you may have heard of a procedure called a tracheostomy. Okay, and so I want to address that. Tracheostomy, the first part of it refers to the trachea, and the suffix ostomy is an opening into. And I'll give you another example, like, I don't know if you've ever encountered it, but you know what a colostomy is. People that have to wear the bag on their abdomen to empty the contents of their colon, but this is an opening into the trachea due to an upper airway obstruction for whatever reason. Could be food, or it could be a crushed larynx, could be anything. But usually it comes in, and if you look at on page 501, right where you are, the diagram here, you see the trachea there.
16-4.
Right, and right below the cricoid cartilage, oftentimes that's where they'll do the trachea. That's just to create an emergency opening into the trachea because there's some obstruction above that in the upper airway. Okay, so a tracheostomy is an opening into the trachea. That is the actual procedure. No, that is the actual opening. The procedure is called a tracheotomy. And that is the physical act of making that opening. Okay? Opening into the trachea. And again, what I mentioned, what they taught me, believe it or not, way back when I was in the military and I was just a young, wet behind the ears medic. There is a membrane between the thyroid cartilage and if you look underneath at this diagram, you see two cartilages. You'll see the thyroid cartilage, which is the so-called Adam's apple. And then you'll see the cricoid cartilage, which is just another cartilage underneath that. Well, in between those two areas, there's a very thin membrane, okay, called the cricothyroid membrane. And I've had to do it twice in my lifetime. And I did it one time with a pen. I took the innards out of a pen, the ink holding plastic part, and then just poked it through the cricothyroid membrane.
Razor blade?
Didn't use blade, didn't use anything, just went force. It bled a little bit, but...
You saved the person's life.
Yes, it opened up their airway because in that area, and you can feel it on yourself, I wouldn't press too hard, but you can feel it between your cricoid and your thyroid. There's that thin membrane there, and if there is an upper airway obstruction that you just can't get out, by the Heimlich maneuver or whatever, sticking your hands in there, you do a cricothyrotomy. And again, the otomy part of it is the actual physical act of creating that opening into the membrane, the cricothyroid membrane. Okay. And that is only to be done in emergency, and it's only for short-term relief of some upper airway obstruction. And I guess that brings a point. When we differentiate between the upper airway and the lower airway, the upper airway generally is considered anything above the vocal cords. Okay, and then the lower airway obviously is below that. All right. Again, don't worry about the difference between the true vocal cords and the false vocal cords. But again, know that we do produce sound by forcing air through there. And it happened to both of us when we were teenagers due to the under the influence of testosterone. The muscles that control the openings or control those membranes, they relax a little bit under the influence of testosterone. So, around age 12, 13, earlier in some males, later in some, their voices drop a few octaves. Okay, and it's because it all has to do with the frequency of the vibration of those vocal cords. Now, you can tighten them yourself and make your voice do something different, because the higher